So here I'm going to talk to you today about the ICE trial. Some of you who know me may know that my interest in research over the years has been surfactant, resuscitation, CPAP, ventilation. So what am I doing talking about cooling for hypoxic ischemic encephalopathy? Well, as a practicing neonatologist over many years, I got rather frustrated by the fact that we were managing these children symptomatically, and yet there was good research going on. Marianne Torrenson, a good friend of mine, showing in piglets that cooling was very effective. And we thought a long time ago now that we should be doing some randomized trial. And in the group I work with in Australia, they were very good at organizing and running randomized trials. So Sue Jacobs was the chief investigator of this trial and has done an immense amount of hard work, and he's very careful and obsessional. And had come back to Melbourne from Toronto, where she'd done a project to design a project on cooling. So I said, good, Sue, I want to do cooling. You know about it. You've done it all. And so, although I'm no expert on this area at all, I facilitated the running of this randomized trial. So the whole idea of this trial was that it was going to be something that was simple and could be done anywhere. One of my things that raised my hand up is that clinical research should, if it works, be applicable in as many places as possible. Yes, you can do research with complicated things, but then very few people are going to apply them. And working in Australia, where we were surrounded by Indonesia and the Philippines and a lot of people from India and China, we wanted to see if we could develop a protocol for treating cooling that could be done without complicated cool cap machines, refrigerators by the side of the bed, a lot of money being spent. So this is what we would call a pragmatic or a simple trial to determine the effects of whole body cooling. What's the point of just cooling the head when there's warm blood rushing up through the carotids into the basal ganglia? So it needs whole body cooling, and 33.5 was the target, not decided particularly by us, but by the piglet researchers, and go on for 72 hours seemed to be what was being recommended at that time. Our outcome was 2 years mortality or major disability. And this trial differs from other trials by combining clinical criteria to identify infants at risk of brain injury. So there was lots of discussion, not to say arguments at the beginning. Should we be using amplitude integrated EEG as part of the criteria? And although I think the research is fantastic, the fact was that at the time we started this trial, nobody had wide experience of using this. And so again, on the pragmatic basis, what was the point of having an inclusion criteria that people weren't likely to be able to use? So identified only by clinical criteria, simple, inexpensive method, I'll show you. And we wanted to be able to start at the birth hospital. Now, most cases of HIE do not occur in the big perinatal centers where the obstetricians, pediatricians, everybody much more experienced. They tend to occur in the smaller hospitals and the private hospitals and one thing and another. So we wanted to be able to start at the birth hospital and cool the babies at their hospital and during transport. And as I've said, if effective and safe, this technique could be widely applicable in many places around the world that could provide basic intensive care. So these were near-term babies. They had to have encephalopathy, peripartum hypoxia, and it was 2 of a low APGAR score, less than 5 still at 10 minutes, need for ventilation at 10 minutes, a pH less than 7 or a base excess of greater than 12 within an hour of birth, and possible to treat at or transport to a participating centre. We wanted to start early, and as many of you will know, the frustration of many of the cooling trials is that really we probably should be cooling as soon as we recognise this baby's got problems, not wait for many hours, warm the baby up and then cool it down again. Anyway, that's what the ethics committees forced us into the position, because we have to get consent, and you have to get there and talk to the parents and so on. But anyway, we wanted cooling to be started within 6 hours of birth. Animal data was that you probably shouldn't wait much longer than that. We didn't want to be cooling tiny babies at this moment in time, and there's a whole list of major problems. Why an imperforate anus? Well, we needed to measure rectal temperature. Oxygen of greater than 80% was these babies would be very sick, and cooling can put up their oxygen requirement, and we thought it was inappropriate. And if the doctors thought that the baby was going to die, there wasn't any point in randomising to the trial. And no active cooling before we'd got consent. So that was the... So primary outcome, as I said, mortality and major sensory neural disability, defined as cerebral palsy. That is, they were not walking. You can have cerebral palsy and still be walking, so they weren't included here. Severe developmental delay, blindness, severe blindness, or aided hearing loss. Of course, we were interested in the secondary outcomes, and you can see for yourself, and I won't go through them all in detail. Acute effects. Was cooling actually causing problems? And at the time we started this trial, this was really early on, and there was a question that it might be causing many problems. We now know that providing you care for the babies properly, this doesn't seem to be a problem. We wanted to see the effect of encephalopathy and different levels of encephalopathy and neurological exam, and they had an MR on day 7. So this was the treatment. The normal babies were kept in the normal range, rectal temperature. The cool babies were cooled to an average of 33.5 was the target, anything between 33 and 34 rectal, and kept cooled for 72 hours. Now the cooled infant was exposed to ambient temperature. We turned off the radiant heater, and as you know, asphyxiated babies get cold anyway. And then the simple cooling was we had cold gel packs. In Australia, they're called cold hot packs. They're blue, filled with jelly. You put them in the fridge and keep them there at 40 degrees, and then they were either put under the head or over the chest and liver. These packs were covered in a little cotton bag, have cold bag put directly on you is very uncomfortable. So here's the baby. The bag's inside this wrap, and then there's one under the head there. And the whole treatment was very simple, is the nurses would watch the rectal temperature, and they would take the packs off or put them on, depending on what the baby's temperature was doing. And as you will see, that was managed remarkably well. So the total cost of the cooling equipment was just a few dollars. So active cooling with the cold packs, we didn't start if the temperature was less than 35.5. If it got less than 34.5, the nurses would start taking the packs off. If the oxygen went up by more than 20%, the plan was to take the packs off. That rarely happened. If a muscle relaxant or anticonvulsant was given, then we were going to reduce the cooling as well. And if it got below 34, then the cooling was taken off. If it got very low, less than 33.5, which was our target, then the radiant warmer was turned on to maintain the baby's temperature. We targeted 276 infants, and you can see you're looking for an absolute reduction of 15%. Now, by July 27th, 2007, recruitment was stopped when we'd only enrolled 221 infants. And recruitment was stopped on two things, really. Primarily, there was a major review published which really showed that cooling babies with HIE was beneficial. And related to that, the people participating in the study, the participating centres, found it difficult to enrol patients because they'd lost equipoise. As you can imagine, once the evidence is out there, you cannot go and face parents and say, please enroll your baby into this study of cooling or not cooling because we'd like to know whether cooling works, when actually you know that people have published that it seems to work quite well. Anyway, we got to 221 infants and decided to stop. So we'd assessed 542 for eligibility, 321 were excluded, 207 didn't meet the criteria for various reasons. Only 33 parents declined participation, 80 weren't approached, and 1 had been treated with open cooling. So we had 110 cooled and 111 controls. 27 of these died, 42 died there, so you will see there's quite an effect on mortality. We lost 3 to follow up there, 10 to follow up there, 80 survivors, 59 survivors. So overall, we analysed 107 and 101. Now, I hope you can read this, but I'll go through carefully. I think I've made a mistake there. There should be, that says 101, but there's actually 111. So there we go, 111, 110. Okay, so this is a bit about the mothers. The more interesting thing is the intrapartum problems. So 7 of the mothers had fevers, cord prolapse, shoulder dystocia, antepartum hemorrhage, some major sentinel event, and suspected fetal compromise, severe variable decelerations, prolonged bradycardia, tachypnea was the major cause of the intrapartum complication, and about half were delivered by caesarean section. So of the babies, yes, they are term babies, they're relatively big. 60% are outborn. Their APGAR scores are terrible, which was part of the thing. They had to have an APGAR score of less than 5 at 10 minutes, so it's not surprising they were bad at 5 minutes. They were all ventilated, which was part of the criteria. 2/3 of them had cardiac compressions, 1/3 had epinephrine. These babies were sick. Not surprising, they had HIE. So APGAR score, these were the criteria. APGAR score less than 5 at 10 minutes, the majority. Resuscitation for ventilation for more than 10 minutes, virtually all of them. And you can see severely acidotic. The assessment of encephalopathy on the SARNAT score was as set out here, so the majority were moderate. There were a few mild, which is interesting when you see all the things that have been going on, but because of the clinical criteria to get into the trial, we've ended up with a few babies with mild encephalopathy, and 1/4 of them had very severe. 1/3 had seizures, and they were randomized on average at 4 hours. The temperature by the time they got into the study was mid-36s. So here's the temperature. This is what can happen if you just do simple warming using cold packs. So here are the controls running along the top. These are standard deviations. Here's the cooled babies coming down quite rapidly. So there's 6 hours. Within 2 or 3 hours, these babies have got down to the target range. Target range was here. And they are held at that remarkably well, I think. I was slightly sceptical that the nurses would be able to hold them. Of course, this is one standard deviation, so 2 standard deviation takes you either side of that. There are some babies getting a little too low. But this is a really, I'd be interested in other people's comments and their experience. I think it shows that you can keep these babies cold by just using this technique. Then at 72 hours, there was a slow warming regime over the next 12 hours. So what about the primary outcome? Okay, so death or major disability at 2 years. 51% of the cooled, so don't believe cooling cures all ills. There's certainly, many of the babies are really still dying or very sick. But in the controls, 2/3, so risk ratio of 0.77, a significant benefit from cooling. So the neurodevelopmental assessment had been done at 24.6 months. So the message from that was that hypothermia done with this technique significantly reduced death or major disability with an absolute reduction of 15 percentage points or a 22% reduction overall. That translates into treating 7 babies with HIE or diagnosed on those criteria with hypothermia would prevent 1 infant dying or surviving with major disability. Okay, busy slide. I'll take you through the important bits. These are secondary outcomes. So we've shown death and handicap. Now death alone. 25% against 38.5. Relative risk ratio of 0.65, a significant effect. So cooling reduced mortality. Here's all the other things about handicap, and if you just look down this side, there are no significant differences there. But survival free of disability, about 40% as against 23%, a significant effect. So no real effect on individual components, but survival free of disability and death are the 2 things that come out of that. So when did they die? What happened here? This shows the first 60 days. There's a Kaplan-Meier plot, and you can see the cooled babies are here, the control babies. So there is some difference in mortality in the first day or 2, but really it's beginning to separate by a week and 2 weeks, and by 28 days there's really quite a big difference. So it's not all in that first day or 2, and I think that's quite important, and I'll come on to in a minute. It's not as if the clinicians were giving the thumbs down like the Roman emperors to the poor gladiators in the Colosseum, that, oh, you're bad and we're going to turn you off, but if you're cooled, well, we don't really know what's happening, so we'll keep going with you. Though there were plenty of decisions about the babies who died, they weren't all being taken in the first day or 2, when most of these decisions have been taken. Now, of course, with all these trials, they're never quite evenly balanced, so there was adjustment for of the primary outcome did show a significant association with the severity of encephalopathy, which I suppose I found quite heartening. So the more severe the encephalopathy, the more likely the cooling was to be beneficial. The protective effect of cooling persisted after adjustment, recording severity at assessment, that's there. And there was no evidence that the effect of cooling differed within the subgroups, stage, outborn status, or age at randomization. Mortality at 2 years significantly reduced. We've seen that. Most deaths in the first 4 weeks. Hazard ratio for mortality after cooling in the first 4 weeks was 0.58. 97% had decisions to withdraw treatment, provide palliative care. or not to accelerate treatment, and I want you to see that this is very similar in the two groups. It's been a concern of mine, not based on any data at all, but that there might be a differential effect in the cooling trials of people deciding to withdraw treatment in the controls compared with the cool babies. What did they die from? Well, severe HIE, refractory hypertension, early onset sepsis, meconium aspiration, but the majority were severe hypertension, severe HIE. Neurodevelopmental assessment, no significant effect on the major things. You've seen that already. Spastic quadriplegia was the major type of cerebral palsy, 71% of the CP cases. Perhaps not surprising. And significantly more survived without sensorineural disability. I've shown you that already. Now, what a bit about the temperature monitoring with this technique of cooling babies. The mean rectal temperature at randomization 36.4, target 33 by a median of 2 hours. So the median time to get down to the target range was 2 hours. 95% were down there within 6 hours, and the other 5% were there within 7 hours. So they came down fairly quickly, but not all of them. Some were a bit longer. Maintenance during was 33.8, so we've seen on the graph the babies were kept in the range and the controls were within the normal range. So from after the cooling period, during the maintenance period, the cool infants were at an average of 3.2 degrees colder than the controls. Now, 106 were actively cooled with the cold packs. 105 of the cooled babies, not all of them, 95%, the others got down to that temperature naturally because of being exposed to the environment and having severe HIE, and one control baby needed to have some cooling in order to keep it within the normal range because it was hypothermic. 64 had at least one temperature below 33 degrees. One wants to be very careful not to let these babies get too cold. The chance of bleeding and other side effects increases very significantly if they go down there. 62 of them were cooled and 2 of the controls. So lowest between 29.8 and 32.9 for the cooled and that for the controls. So some of the controls were getting down there even though people were trying to stop them. Other effects of cooling. Heart rate. Heart rate is slower. 114 cooled, 139 for the controls. Not surprising. They get a bradycardia. More cooled infants had significantly prolonged ventricular contraction and QT infant compared with the controls, but none had a cardiac arrhythmia requiring medical treatment or the intervention being stopped. Intervention was discontinued in 6, 3 with severe coagulopathy, 1 who'd had a subgaleal bleed evident immediately after randomization, 1 with a pulmonary hemorrhage, and 1 withdrawn at the parental consent, and 2 at the doctor's request, parental request and doctor's request. There were no statistically significant differences in any other possible complications during the cooling. So coming towards the end, what points can we highlight? This technique of selecting and cooling babies with HIE on clinical criteria, not using an EEG, significantly reduced the primary outcome at 2 years. Mortality was reduced with no increase in major disability. 15% reduction in the primary outcome is consistent with the NICHD cooling trial, the CoolCap trial, and the TOBY trial. So it's heartening that this technique is having an effect which was within the sort of range seen by other trials. But the ICE trial is the only trial showing a reduction in mortality. But this is consistent with the pooled analysis in the Cochrane review. The relative risk for mortality was 0.74. So I think one doesn't want to overplay that. A lack of significant effects on the components of the sensorineural outcomes is consistent with the CoolCap and the NICHD trials, but not with the TOBY trial that showed a significant reduction in cerebral palsy in cooled infants. This may be due to the sample size and other methodologies in randomized trials. ICE had 221 babies, CoolCap had 218, NICHD 208, compared with the TOBY trial which had 325. And if you look through the trials, there are differences, not significant differences, but these are actually, in terms of neonatal randomized trials, are relatively small numbers, and you're not going to see what might be considered more subtle effects. The significant increase in survival without neurological disability observed in our study was also reported in the TOBY trial. So, simple whole-body cooling started within 6 hours of birth, reduced death or disability at 2 years of age in term infants with moderate severe HIE. That's not quite true. There were 1 or 2 mild as well. But the effect was more in the moderate and severe. Clinical criteria were used soon after birth to identify the infants. So this simple method of cooling without complicated and expensive equipment, effective and could be used in any NICU or even non-tertiary or low-resource setting, as long as they can monitor temperature and other parts. The babies need to be carefully monitored. You don't need to be spending a lot of money, and you can do this during transport. Sorry, that's the end. Thanks very much.
How did you define the definition of encephalopathy? Did you use the Sarnat scores or did you use Thompson?
Sarnat scores.
Okay.
Colin, one of the problems with cooling is like everything else we do, if we treat the right patients, then it's probably a good idea. If we treat the wrong patients, it's probably a bad idea. And the problem is identifying quickly the patients who actually have the encephalopathy. It's easy to measure our encephalopathy for some of us. It's easy to measure blood gases and do APGAR scores and things like that. But ultimately, you've got to assess the baby. And how quickly can that actually be done? How old does the baby actually need to be? Because there's a great tendency to just cool everybody and to start cooling in the delivery room. And how do we make that cut?
Well, I mean, you can all answer this as well as I. I mean, I'm no expert on this, but you know, my feeling, I would like to see some trials done right straight after birth. And my basic criteria would be, oh my God, this baby, you know, it's bradycardic, it's ventilated, we're having troubles resuscitating, it's acidotic. This baby looks... Well, okay, but, you know, cooling doesn't seem to do any harm. Okay, it might be uncomfortable and perhaps we should be giving them morphine and various things, but, you know, if cooling is going to work, physiology is you really probably need to start within an hour or two of birth. And so I like, I'm a clinician, you know, we've all seen these babies with, I'm not suggesting anything subtle, babies who are obviously had a major antenatal event and come out flat as a tack, you know, bradycardic, needing lots of support. Why wouldn't you want to cool them? Anyway, Madonna, you tell us these answers.
I think it's very difficult to assess encephalopathy very early, especially. I think that was the value and benefit of doing amplitude integrated EEG, because at least you had a measure of depression in the baby. Harvey Sarnat never designed his scoring for these purposes.
No.
And so I think we have to take that with a grain of salt when we keep referring back to the 21 babies that he did that study because he was looking at EEGs and he had no idea that it would end up where it did. That having been said, we see babies who are very hyper alert, who are as sick as the babies who are very depressed. It's very difficult for people who are not used to seeing those sick hyper alert babies to call that encephalopathy. So it's still difficult, and I'll touch upon this in my talk. The question I have for you was, you nicely told us about the dips, the hypothermic dips, but what about the hyperthermic dips, or peaks rather, because as you know from the CoolCap data, the babies with pyrexia did worse.
So for the cooling babies or the control babies? The cooled
Both.
babies?
Both.
I'm afraid I'm going to duck that. I can't give you that answer. Sue, where are you? I need you.
Because this is a very important thing. If you have a few babies who are having higher temperatures, as we showed in our publication, which was not presented here, the Neo-Neural Network trial published its result in October last year. And we showed that for each degree above the range, you have a 5-fold higher odds ratio to have impairment. So any increase in temperature plays an important role for all assessments. So I think each publication must sort of reveal how many babies had higher temperatures. And that maybe also relate to the time after cooling, because if they have fever afterwards, it may still influence the outcome.
I accept that, but you know, within this, trying to do randomized controlled trials, you have a protocol. What we've shown is with this protocol, yes, there's some babies a bit too cold, some babies a bit too warm, they're oscillating, but nevertheless, it has shown a beneficial effect. If we were to then cone down and say, okay, so we've got 10% a bit too high and 10% a bit too low, the numbers would be too small to really make any definitive analysis of that. So I think it's like all randomized controlled trials, you must be very careful not to try and get into all these minute subgroups of what might have happened, this, that, and the other. And if I just allow me one more comment with Donna. So if the Sarnat score is not very useful, the EEG might be useful if you can actually got somebody who can put it on and interpret it, but it takes you, a while to do it. So, I come back to simple clinical criteria. If you can't do the Sarnat score and you can't do the EEG, then you just take, hey, all you guys, paired eyeball test. You can see this baby's in trouble.
Yeah, but the problem with that is it's a slippery slope, because there's a bunch of these babies who shouldn't be cooled because they're going to die. And then there's some of these babies who look really bad, but with an effective resuscitation just turn right around. And you can't really figure that out who's who within the first 20 minutes or so very easily. But I agree with you, the biology is you should cool them quickly. But I think this temperature issue is really important. And I agree, you can't parse the trials too much. But on the other hand, all of the trials, or at least the trials that have been looked at, suggest that hyperthermia is really bad for you. And I think that there's a message for the developing world and all of us about this whole issue of hyperthermia, because we have focused as neonatologists for the last 50 years on preventing hypothermia, or 200 years. And the problem is, I've seen a data set now on 150,000 deliveries from home deliveries and level 1 clinic deliveries in India and Africa. And the incidence of hyperthermia documented by whoever was doing the delivery is 3 times the incidence of hypothermia. And in our own data sets and in other data sets from NICHD and whatnot, It turns out now with the massive effort to avoid hypothermia in our tiny little babies with bags and all these things, some of these babies arrive in the NICU hyperthermic. And that's probably actually a lot worse for them than hypothermia, because the original temperature trials were actually on chronic babies, not on these acute events. And you know, if you think about most mammals, they actually become a little bit cool after they deliver in a snowbank in Scotland.
So lambs being delivered out on the countryside, but I come back to, okay, so we're after clinical messages. The clinical message now, I think, should be, if you've got a baby that you think might be in trouble in that throat, for goodness sake, don't keep it warm with the heat going down on it, heating up the baby, and then later on, oh yes, perhaps several hours later we better cool this baby. And so, that's extrapolating beyond the data, but it's going to what would seem to be, taking your thing, logical, is turn the heater off right from the start.
I just want to mention for the audience, we did a neural network trial in Europe which used the Thompson Score. He did not mention that paper, but we used the Thompson Score, and the Thompson Score is now analyzed and has a very, very high predictive power. It's actually the score which can be done immediately, has less items to assess, and gives a scale from 1 to 23. So that's the way I believe to go. We will show in the analysis of the Thompson Score that it has a very high predictive power. It's actually what you say, a quick clinical assessment of the neurology of the patient. So if you read our paper, you will see that the Thompson Score is a very good way to use and is nearly equivalent to the HIE. We also analyzed the correlation between the two. So maybe the audience needs the audience. Any questions from the audience? Please.
So an additional remaining question is, how can you predict the onset of HIE? Is it an acute event, or is it something that happened already several hours ago in utero?
Well, we need done with that, but we all know this is one of the problems with the cooling trials. This baby might have been chronically asphyxiated, even having previous episodes when it's nearly died and recovered, or it may be an acute episode. And so we're getting in these chronic babies with the acute babies, and we're really not quite sure.
Now you can imagine if you could extract all these chronic babies out of the analysis, how powerful the cooling might be. Again, it's extrapolation. But
there's a very nice paper from an obstetric team in Bristol in England that actually showed that if you really get the midwives and the young obstetricians applying what we know of recognizing things going wrong, hey, you can halve the incidence of severe HIE, so you don't need to cool many babies. I think that's a matter of the obstetricians recognizing things from what you're saying. And we're pretty bad at that, those sort of things.
yeah, and one interesting aspect of perspective that was that on your slide you had all the causes of HIE, and the most common one was suspected fetal compromise, meaning that you don't actually know what happened. But again, it comes back to analyzing exactly, paying attention to the detail.
Yeah. Question over that?
I'll
One of the problems with the hypothermia that you are getting baby, that you cut down the mortality, but most of these babies who should have died actually are basically is a major neurological disability. That's why maybe you haven't seen some improvement in the neurological assessment. Some of the babies who should have died actually survived, and are neurologically
Yeah, but what we showed was that of the survivors, there was no increase in disability. And that's come out of the other studies as well, in the Toby trial. So that was one of our major fears. We keep the babies alive only to be severely handicapped. And what we're learning now is cooling has some beneficial effect, mortality and neuro disability, and we are not increasing the number of survivors with disabilities.
Preterm infants age, gestational age 32, 33, severe asphyxiation. Would you recommend it?
There's a research project for you to do. I mean, we haven't a clue. Well, we might have clues, but we haven't any data.
What do you do in the day clinic?
What do you do? Prayer, fasting, supplication. There is no data about what we should do on premature babies. As far as I'm aware, Donna, I mean, we've got experts here.
Can I?
One trial.
There's a trial being done, we don't know.
There's a trial being done.
There's also one published where they use hypothermia for prematures between 32 and 37 for babies who were in having necrotizing enterocolitis. It was a sort of pilot trial, and they showed it was feasible. You know, that means it does not cause tremendous side effects. That is all what is known at present. Actually, if I may, Corrado, suggest that Dr. Valero continues now, and she will also talk about hypothermia, so you can think about questions and then ask them together for Tony and her. Okay?
Can I just ask one question?
Sure.